Hi, everyone. Welcome. My name is Melissa Wilson. I am a physician assistant from Hillman Cancer Center at Pittsburgh, Pennsylvania. I am also a melanoma's Ask an Expert. You are joining us tonight with one of my favorite guests, Dr. Allison Betof. She is Associate Professor of Medicine and Oncology. She's Director of the Melanoma Program and Director of the Solid Tumor Cellular Therapy, and also a Mark and Mary Stevens Endowed Scholar at Stanford University. Tonight, we're going to talk about what to do when first-line therapy fails. So the title of our webinar tonight is You're Not Out of Options, What to Do After First-Line Therapy Fails. I think this is an extremely important topic, especially now because we have such wonderful therapies in melanoma, and unfortunately, they don't work for everyone. So, I feel like this is such an important aspect to talk about because not everything works for every patient. So, what do we do when our melanoma treatment stops working? So tonight, Dr. Betof is here to join us to explain all the things that we need to know when moving forward in this journey. So Dr. Betof, thanks for joining us.
Great to be here. Great to be back here, I should
Yes.
say. Thrilled to be with everybody. And I do think this is one of the more important topics we talk about. The last decade or so, we spent so much time trying to, tell everybody that they needed to get on immunotherapy, right? And
hmm
and make sure that people were getting the appropriate first line therapy. And now, I think it's really important that we make sure that people understand that that is not the end all and be all.
Exactly. I mean, folks, probably one of the biggest questions that I get outside of like symptom management on my Ask an Expert line is, I failed treatment. What do I do? Well, what happens next? What happens when this treatment didn't work for me? So the one thing that I wanted to kind of start by kind of framing is that there are two reasons, maybe why your treatment has failed or why the treatment doesn't is no longer working for you. It could be that it's no longer holding your treatment or your tumors back from growing or progressing or metastasizing. But it also sometimes patients, fail therapy or go off of therapy because of toxicity. So I think like those are two really important things to kind of separate out because they both result in us having to find a new plan, right?
Yeah,
So,
I think one thing that patients don't always understand in that scenario, though, is if we have to stop treatment because of toxicity, we don't always have to start another treatment, right?
mhm.
Oftentimes, that means we've gotten enough immune activation that will continue to work for days, weeks, months, and sometimes years and decades, and patients may never need another treatment. So I have this conversation a lot of people who are like, I have to stop my treatment. Now what do I do? And I'm like, absolutely nothing. It's working.
Yeah. Right. So,
Your immune system's doing the work.
if things are stable and there's no evidence of progression, we just kind of watch patients. Is that correct?
Yeah, absolutely. And we're watching closely. We're prepared to make a different move if we need to. But historically, if you look at the data from many of the clinical trials that we now have, 10 plus years of follow-up from, many of these patients will never need another treatment. So I think that's just an important part of this message, right? A lot of what we'll talk about today is, of course, what to do if the treatment is not working. But again, to your point, those aren't the same thing. Having to stop because of a side effect and having to stop because it's not working are really not the same thing.
So now that we've kind of established that, what if we do really have like how do we know that a treatment truly is no longer working for a patient? What
Yeah, so
modalities are we kind of using?
mostly imaging, right? So most of our patients come in and they say, "What's the blood test that can tell me, if this is working?" And I wish there was one, right?
So much.
So much, so
So
much.
much.
People certainly sometimes follow LDH, but I will say that LDH is very, very non-specific. I do
Mhm.
not use it for that purpose in my clinic. LDH can go up if you're having inflammation and side effects. LDH can go up because your tumor's dying really quickly and releasing LDH because the tumor cells
Mhm.
do that. And LDH can go up if the tumor's growing. So it's not a great marker. Lots of questions about the role of ctDNA right
Mhm.
now. And, I spend a lot of time talking to patients about ctDNA, but realistically, right now, ctDNA has not been validated for that use in melanoma. There are some other cancers where ctDNA is a little bit more advanced, but right now the sensitivity hasn't been as good as we'd hope. And so I also don't use ctDNA for that purpose. And we really are using images, and that's CT scans, PET scans, sometimes MRI, depending on what we're looking at. And sometimes even then it's not clear, and we actually have to biopsy to figure out if something is inflammation, which
Hmm.
we absolutely can see, and we can see things look bigger or new things that are truly just inflammatory from immunotherapy versus truly progressive melanoma.
Yeah, that's a really, really important point because we have seen, the tried and true images really, we try to tell patients all the time, like, listen, imaging, it may be old, but it doesn't fail a lot of the times. So, that's one thing to like bear in mind. And the other thing is that at least we found with our ctDNA monitoring, like the same reasons that LDH goes up, we also have seen like with, tumors that are shrinking rapidly, we've seen that ctDNA number go up before it went down. So there's lots of kind of, nuances to determining whether this is working or not. And to your point, I mean, there's been plenty of times where we've had, especially with immunotherapy, lymph nodes pop up places that end up being sarcoid or granulomatous changes. And, so I think the biggest take home message for our patients is that yes, imaging is probably the most dependable, but we also have to use some of the other tools that we have to kind of make these determinations and really truly decide, right? Um, I think so now we've determined that, like, say, okay, our treatment, our first line treatment, which I would think in this particular instance, we're assuming that patients are on some type of immunotherapy as frontline, right? So for the sake of this conversation, we'll go with that. So at what point, what kind of questions should the patient be coming in with for this discussion? Like, do you have suggestions for like these are the talking points that we kind of want to go over when we're thinking about next
Yeah.
lines?
If we're thinking about next lines, I think one of the most important questions that you can ask is, have you sent next generation sequencing?
Mhm.
It's 2025 and I'm still shocked by how many patients have not had next generation sequencing on their tumors. And, many, many people know about a BRAF mutation and know to ask for that. But there are other mutations in
Mhm.
melanoma that are actionable, meaning we have drugs that can target those mutations, things like c-Kit, and even much less common but very effective things like NTRK mutations, which have
Mhm.
newer drugs for them. And even NRAS, which was traditionally thought of as a non-druggable
Non, right?
target, quote, right. First and foremost, our FDA approved drugs are MEK inhibitors, things like
Mhm.
Mekinist, have some efficacy against NRAS mutated melanoma, but additionally, there's a bunch of trials in this space.
Yeah.
And so, if someone is thinking about immunotherapy that is no longer working for their melanoma, that's questions number 1 through 5 in my mind.
Yeah. So just
Um,
because people might not know what is
sure.
next generation sequencing.
Yeah. So next generation sequencing is basically genetic testing on the tumor. And people get nervous when we talk about genetic testing. We're not talking about genetically inherited mutations or
Right.
mutations that can be passed down in families. We're talking about mutations in the melanoma itself. And so when, the sun ray or whatever caused the melanoma came in and caused that particular mutation, these are on signals for the melanoma. They tell the melanoma to grow. And just like BRAF, right, where we often think about having a pill that can turn that on signal off. Again, there are others of these that are potentially targetable.
So besides next generation sequencing and all the other BRAF, all the molecular testing, what other questions do you think are important for a patient to be really armed with whenever we're going in?
Yeah, so the next question I would be asking is, what are my clinical trial options?
Hmm.
Right.
For sure.
And that's not to say you have to do a clinical trial at that stage, but many of the treatments that we know of are most effective when given earliest after progression on
Sure.
immunotherapy. And so, it, I always counsel patients who come to me or, come to me as a second opinion, newly progressing on immunotherapy. What I would be thinking about is, of course, BRAF mutations and other mutations. the next question is there a TIL center near me if I'm not currently going to a TIL center? And how do I get evaluated for TIL? Um, and and what are the clinical trial options that are available to me? And before I picked a next line of therapy, I would ask all three of those and be discussing all of those options before I just immediately moved into a next line of therapy.
Okay. So, I mean, hoping to assume that most of our listeners, because we have very, very educated listeners, know, BRAF mutation and what those entails and things like that. Let's talk a little bit about TIL therapy because
Yeah.
there are a ton of questions that come up in my practice and with the accident expert line asking like, when is the right time to do TIL? How do I know that this is the right
Yeah.
time? Because
Yeah.
there is no right time, but when is the
There,
right time?
there is no perfect time, right?
Correct.
One of my patients jokingly said to me the other week that it's sort of like when people ask when's the right time to have a baby. Like,
Yeah.
well, I don't know.
Yeah.
But there is no perfect time, but in general, for a patient who wishes to consider TIL and is eligible for TIL, the answer in general is as early as possible after
Yeah.
progression on a checkpoint inhibitor. In
Yeah.
fact, I had this conversation with several patients in my clinic yesterday saying, oh, well, I'm thinking, maybe I'll do a trial or two first and then, try some things out. And then if that doesn't work because TIL sounds so hard, I would come back and do TIL. I would tell you,
Hmm.
everyone has their own opinion about this, but I think that is exactly the wrong approach here. And the
Sure.
data actually would back that up, right? So, we have data from, of course, the C-14401 trial, which was the trial that led to the approval of lifileucel or Amtagvi commercial TIL therapy, where patients had, up to, median of 3 prior lines of therapy and sometimes up to 7, 8, 9 prior lines of therapy. Um, and then we have data from the Netherlands Cancer Institute study in Europe where patients had only had one prior
One.
line of therapy.
Yeah.
And the difference in response rate is 20%. And the difference in complete response rate, meaning all melanoma gone, right? That trial achieved a 20% complete response rate, right? And so I think it's really important, one, for potential efficacy, but also if patients are sicker,
Yes.
um, more beat up, either from disease or from side effects of, potential therapies, TIL becomes exponentially harder
Absolutely.
on the patient, not the doctors, although also the doctors, but on the patient, and sometimes impossible,
Yeah.
right? And there are many times, unfortunately, where patients wait, quote unquote, too long if they wanted to consider TIL, and they come and we say, I'm really sorry, but you're not fit for TIL anymore.
Sure. Fair. And,
And I think people need to know that that's a possibility, right?
yeah, absolutely. And, the other kind of myth that sits out there is that once I've had TIL therapy, nothing else is going to work, which
Yeah.
I think is completely
Or
insane.
that I'm
But
not
yeah,
eligible for anything else.
right.
And those are two myths that are out there that I get asked by pretty much every patient who walks in my door to talk about TILs. And
Hmm.
these myths are wrong.
Yeah.
Um, like they're just wrong. I mean, again, I had this conversation with a patient over a period of more than an hour yesterday, which is like almost all of our patients who have gotten TILs, who have not been fortunate enough to have a durable response, who have wanted additional therapy, and not every patient does want additional therapy,
Sure.
but almost all of our patients who wanted it have gone on to additional therapy, including other clinical trials with efficacy after TILs. There is a very small subset of patients whose blood counts don't recover to sufficient levels. I will say that, last year, about a year ago at Society for Melanoma Research, I actually presented these data to put them out there because we kept hearing this. That
Yeah.
number's way less than 1% of patients who get TILs. So can
Yeah.
it happen? Sure.
Sure. Yeah.
But you also can get too sick from frontline checkpoint inhibitor to get something else, and that doesn't stop us from giving frontline checkpoint inhibitors.
Fair. And the misnomer that like we can't do clinical trials after we've had TIL therapy is just it.
In
Yeah.
fact, there are many, including other cell therapy trials now,
Sure.
that absolutely allow prior TIL therapy. several companies out there, and we're participating in them, and we're treating patients with other cell therapies even after TILs.
Okay. Now, would there ever be, this is a question that came up in the question and answer, would there ever be a time where we would consider re-challenging with immunotherapy that has already been given after TIL therapy or trying TIL therapy again?
Yeah, so I think both of those are good questions. They're slightly different.
Yeah,
We presented some data last year at ESMO, which is the European Society for Medical Oncology, about the efficacy of checkpoint inhibitors after progression on TIL. And the response rate was pretty low. It was about 7% of patients. We looked at about 109 patients across 10 international centers. Um, Now, what I'll say as a caveat to those data, right, are all of those patients were patients who were treated on some of these clinical trials. And so many had had a lot of
sure.
checkpoint inhibitor before, right? These weren't patients who had had, nivolumab, relatlimab, then went straight to TIL and hadn't had ipi-nivo, right? These were mostly patients who'd had months, if not years, of checkpoint inhibitor, then went to TIL when a trial slot opened up, and
Yeah,
then we re-challenged later. So I think in the more modern era where we are using TILs as a second line option, we are going to have to relook at this as the data mature. We're just not ready to do it yet, right? The
not
data
there yet.
aren't mature enough and we don't have enough patients to do it yet. So would I re-challenge? For sure, and I do it in my patients.
Yeah,
It has been shown to be safe, so that is not a concern, and that is something that we studied in our patient population, right? There was some concern that if you give 70 billion T cells, are you going to have this huge inflammatory response if you
sure.
give immunotherapy afterwards? And we have not seen that. So I think that's reassuring. The other question you asked is like, would you give TIL after TIL? And the answer is we've done it.
Sometimes. Yeah,
We've done it. It has to be the right patient. Um, you know, Fit, healthy, good bone marrow recovery after the first one. But as I said, there are several trials that are allowing this now.
sure.
And so, it's on the table for sure. And particularly patients, for example, who got a good response to TIL, and maybe over a period of time, lost that response. I mean, yes, it's tempting to try it again, and we have done it in a very limited number of patients.
Okay. So let's say, okay, we've done TIL therapy or we haven't, or we're looking now more at clinical trials. Um, this is such a daunting thought for a lot of patients because there are so many options. I
Yeah, which
mean,
is a
a good
spoil of
problem to
riches
have.
here, right? It's a
Yeah,
wonderful problem to have. For a long time, there were none. So,
correct.
but yes,
But where do you even start to try to navigate this ship, I think,
yeah.
is where we're kind
So
of going.
what I would say here is this is the time where at least second and sometimes third opinions, I think, can be very helpful as long
Mhm.
as you're not taking too much time. The place I do see people get in trouble is like, oh, I want to see five doctors
Right,
and pool and take a vote, and like you waste 2 months trying to do that, and then the cancer's growing,
right.
right? But certainly if you're not, being seen at one of the big melanoma centers that has, five, six, seven, eight, nine, 10 trials at their disposal, like I strongly encourage patients, this is the moment.
Yeah,
Because there are nuances between all of these trials. Sometimes, there's a big conference this weekend. We may know more on Monday than I know today.
sure.
And so, it's really a true dedicated melanoma expert that's going to be able to give you the best opinion on this. And beyond that, I think there's a little bit of, which route do we want to go? So, for example, some trials are immunotherapy, some trials are cell therapy, some trials are targeted therapy, right? For patients, in my practice who, for example, have tried three different types of immunotherapy trials, I'm like, you know what, we should probably change strategies.
Yeah,
Like,
let's
if
take a
all three
left.
of these strategies hasn't worked and we took three lefts, let's take a right,
Yeah,
and try something different.
sure.
Um, and it's a little bit of what, shape you're in at that moment in time. Certainly there are some really promising new cell therapy strategies and trials, but patients need to be fit enough to be able to undergo cell therapy? Do you have brain metastases? Some trials allow brain metastases, other trials do not. Have you had prior significant side effects with immunotherapy? Because some
That's a
trials
tough
allow
one.
that and some
Yes.
don't,
Yeah, that's a tough one
right?
for some patients.
Any immunosuppression required either now or in the past, right? All of these are different for different trials. And so I will say, I think this, as I said, I think this is the moment to go see, you know, a truly dedicated melanoma expert because this is complicated and there's a lot of nuance to that. But the nice thing also is this is often not one and done, right? If you try
Right.
something and it's not the right fit, then we can move on to another trial, right? And I think sometimes people get so hung up on trying to pick the perfect trial that again, they wait too long to do that.
Agreed. And I think one of the things that you said too, this isn't just one size fits all. And there are very few trials that I've seen now that are kind of really active now that are very restrictive in terms of like prior number of prior therapies. In the past, we did
There
have a
are a
lot of
few.
that. There are
There
some,
are
but
there are some.
not everywhere. Like there
Yeah.
are plenty of
But
options
there
that do
are
not exclude
plenty of
those.
options that do not limit that right now.
Yeah.
Yeah, so I think, if that's another myth that's out there, like if I've had more than one prior therapy, no trial will
Yeah.
take me. That is a
Right.
myth.
Yeah.
The other myth is if I've had brain mets, no trial will take me. That is also a myth,
Yeah. Especially
um,
now. I mean,
especially now.
yeah.
And so, I think go ask, don't assume because there's a lot out there right now.
Yeah. Now, let's say that like I live in the middle of the Midwest where there isn't a giant, center nearby. What kinds of resources do you recommend, for those types of patients in terms of getting to a place?
Yeah, I mean, I do think this is really challenging, right? And asking patients to travel is really challenging. Groups like AIM, I think, have some wonderful resources to help people at least learn about what their options may be. And then, people can reach out to a center, call the new patient line, find out if you might possibly be eligible for a trial before you travel, right? A lot of times, our clinical research coordinators will pre-screen patients, and they'll run them by me before
Sure.
we ever book an appointment so that, patients aren't committing to flying out to California if we don't have a great option for them.
Absolutely.
And oftentimes, if I don't, I may know where there's a different trial that might fit, right?
Right.
The melanoma world is very, very small. We are
Yes.
all friends. We all know what's going on pretty much everywhere in the country.
Yeah.
And so I think, reach out first, but I will say, unfortunately, patients may need to travel if you have the ability to do it. And that's where places like AIM, and I will say also that like American Cancer Society has
Hmm.
some funding support to help with this for some patients. And
Yes.
so, if it's possible, it is certainly worth looking into.
I said, I just had a patient call this afternoon with this exact problem. I live in this really small town. There's no oncology center anywhere nearby. I want to send my records somewhere. Where can I send them? I was like, oh, I know people that are not just 2 states away from you. We'll send your stuff there. Like everything will get taken care of. And I think this is important too for like the small subset of like the smaller melanoma groups, the acrals and the
Yeah,
mucosals and
for
the
sure.
folks that have brain mets and ocular.
Yeah,
That
UVLA, I think
networking is
especially
so
for sure.
important.
Yeah, for
Yeah.
sure.
So, I mean, I think the biggest thing is, reach out to someone, call that center that's in California, call the East Coast, call some folks and see. Because I think, one thing is that just because you don't have it doesn't mean someone doesn't. And there are centers that run multi-center trials that maybe, we're 7 hours away from you, but someone's two. So I think
Absolutely.
that's the message that I, want to make sure people see. I wanted to get to like a couple of these questions. One of the patients actually just didn't really understand what cellular therapy was. Could you talk a little bit
Ah,
about
yes,
that?
sorry.
No, you're
Sometimes
good.
sometimes I forget that we use words that people don't remember. TIL therapy is a type of cell therapy. So cell therapy basically means using T cells as a treatment. So the goal of immunotherapy, as we think of it, checkpoint inhibitors, is to activate T cells, but sometimes that doesn't work for all the reasons that we've talked about. And so there are various types of treatments, including TILs, but also beyond TILs, where we can engineer T cells and then infuse them to a patient um, as the therapy itself.
Okay. Um, Now, do you know of any of these that cross the blood-brain barrier? That's another question that,
Oh,
like the
yeah.
hot ticket.
Well, yes. So interestingly, we actually did the first study of TILs for brain metastasis, and we did show that there is potential efficacy. It is very risky to do. It is not something to do lightly, and requires a lot of discussion. But TILs can get into the brain. There are some data where other T cell therapies may also get into the brain, although a little bit earlier on that, on that front.
Or
Certainly checkpoint inhibitors we know get into the brain. CTLA-4, so ipilimumab, both PD-1 drugs, and now we have data for nivolumab plus relatlimab
Mhm.
in terms of brain metastasis. BRAF plus MEK inhibitors absolutely have brain
Absolutely.
activity, which therefore also means that the patients with NRAS mutations who get a MEK inhibitor
Mhm.
can also benefit from that. Um, KIT inhibitors for patients with KIT mutated, which is mostly our acrals and our mucosals. KIT inhibition, the data are less clear, but there are some intracranial responses with KIT inhibitors. And I will tell people that there are a bunch of trials out there right now, particularly with BRAF inhibitors, that are specifically engineered BRAF inhibitors to try to increase brain penetration. There are two main trials, but a bunch of other ones. Yeah, lots of work on this front for sure.
One of the other questions that has been coming across is, where, there's this sort of with the TIL trial data with how mucosal patients did versus the cutaneous patients in terms of response rates. And, are we able to use TIL for this mucosal population? Is it, worth it in terms of response?
Yeah, so the data out there right now are small numbers,
Mhm.
but they're out there for both mucosal and acral. Uveal is not included in the FDA label. That's something we get asked a lot.
Mhm.
But for mucosal and acral, the mucosal from the C-144-01 trial was a small number of patients. Off the top of my head, I believe it was 8 patients with 4 responders. So, half the patients actually,
That's pretty good.
which is pretty good. Again, a really small number of patients. And so, 1 or 2 responses in either direction, really dramatically influence that statistic. But again, proof of principle. We in our practice treat mucosals all the time with TILs. I've
Mhm.
had responses in our mucosals. And so that to me would not be a barrier to considering TILs.
This question that we just got anonymously was, why mucosal melanoma have much less success rates with immunotherapy than cutaneous. And I guess part of this too kind of runs into like, why are these groups excluded from a lot of
Yeah.
the clinical trials?
Yeah, and it's actually kind of a bummer, right? In the old days, we didn't have such clear data, and so the companies didn't
Mhm.
always exclude mucosal from these trials,
Sure.
and we just sort of slid them in there. And then everyone has sort of wised up a little bit, unfortunately. So mucosal melanoma has lower response rates. There's no question about it, but can be responsive. So also hear that. But there are likely many reasons for that, but I think probably the most common reason that we all cite is that, these are not UV-driven cancers. They do not have the same number of mutations, and therefore it's harder for the immune system to recognize that melanoma and clear it, to attack it and say it's foreign. That is probably one of only several reasons, but it is probably the more common reason you'll hear us use. And so, yes, unfortunately, mucosal response rates are lower, and unfortunately, mucosal now is excluded from several trials, but there are also several trials that do allow mucosal and a
Mhm.
few mucosal specific trials out there.
Exactly. I don't want to run out of time before we talk about this really, really quickly, but the last thing that I wanted to kind of get your advice on is, kind of advice for patients about how to maintain their quality of life and sort of coordinate support as they're kind of going through these, second, third, fourth line trials
Yeah.
or treatments.
First and foremost, ask your centers what is available. Ask your doctors, ask your social workers, ask your nurses what is available at your center. Oftentimes, there's so much more support than people realize.
Mhm.
Things like physical therapy, occupational therapy, nutrition support, but also things like transportation support and financial support for transportation, right? So that family and caregivers, one, can get a break sometimes, and
Mhm.
two, can spend their time actually spending quality time rather than always being a caregiver.
Exactly.
So all of those things, I will also say that diet and exercise in my brain are, by far some of the most important things that patients can do to maintain their quality of life, high protein intake, high fiber intake, and certainly trying to get, 75 minutes a week of some form of exercise.
Absolutely. I think we forget we're so focused on kill cancer that we forget we have to keep our protoplasm healthy also. So,
Well, in fact, when we're talking about any immune-based approach, whether that's immunotherapy, TILs, whatever, you're using your immune system.
yep,
If the body's not healthy, your immune system's not healthy. And
yep,
so, I tell my patients all the time when they ask about should I stop eating sugar, right? You have to feed your body the same, and that feeds your immune system.
yep. Yeah, we forget that we're all connected. We're all in
We
this
are
together.
all connected and we are all in this together.
Well, I wanted to just, cut us off there. I think that we could spend another 2.5, maybe 3 hours talking about all the possible things that are out there, but I just want the take-home message to be there are other things out there. Don't think that if frontline therapy isn't working, that there aren't many, many, many lines of therapy to go that are optional for you. So,
Absolutely. Thank you so much, Melissa.
gosh,
And I hope this was helpful to everyone.
Allison, this was amazing. Dr. Betof, I'm beyond thrilled that you came back to join us. I hope everyone got a lot out of this webinar and hopefully we'll be back again soon.